All right. Hi, everybody. Dr. Nikita Vizniak here. And now we are going through an intro to conditions of the ankle. So some of the key basic things that we should definitely cover with this process as you are doing ankle evaluations. Everybody knows the process by now, if you're into this region of the text or if you're into this area of the website. A couple of key things for you to get. We go through our anatomy first, then we look at our assessment protocols and eventually working into the actions that we want to follow. Of course, remembering when you have the orthopedic conditions text, you also have all of your conditions listed at the very front, inside the front cover if you want to find them rapidly, or same thing on our website if you're looking at it digitally. But remember, your learning is better if you learn from paper. Okay, why the brain prefers paper? You will learn it and retain the information far better from a piece of paper, or if you write it down and make your own flashcards. Okay, so how do we start? Of course, we would start off with our basic anatomy, reminding ourselves of the bony orientation of the phalanges, of the metatarsals, of the tarsals themselves, the medial and lateral longitudinal arches, the transverse arch, right? We would go ahead and quiz ourselves if we wanted to by just covering up 1 through 11 and then say, what is this? What is this? What is this? Great review to go over the basic anatomy. And then a little bit of functional anatomy here when we're looking at overpronation, how that can cause a valgus shape in the knee and internal rotation of the hip and a pelvis misalignment and a shoulder misalignment. However, the clinical relevance of this is debatable. In some people, this will not matter at all. In other people, this may be a pathologic generator. So foot patterns for flat feet, you can see, of course, that overpronation, more wear on the medial side. You can see that valgus shape on the back where the Achilles tendons would be coming down and that change there versus a normal, quotes, normal foot fall and orientation. And then, of course, a higher arch or a supinated foot and how that turns everything out and puts you more towards a varus shape at the knee. So good, quick little intro right there. If we move on, we can now remind ourselves of the ligaments of the ankle as we're building up our story of anatomy here. So we go ahead and have our anterior and posterior talofibular ligaments, calcaneofibular ligament, and if you've done a really good job of your ankle sprain, you may have also damaged the anterior and posterior tibiofibular ligaments. On a medial view, we can go ahead and see that deltoid ligament with all of its parts. And when we talk about these sprains, I will show some cadaver dissection video that shows this as well. Of course, on the bottom of the foot, we can see the long plantar ligament running down at the very bottom, nowhere near the plantar fascia because there would have been muscles and then there would have been the plantar fascia very superficial or near the bottom of the foot there. And then I do have to make a comment because a lot of people haven't seen this before. If you do a dissection of the foot, everybody likes to think that the ligaments are these nice, unique bands and structures like a lot of artists draw them. In fact, they are not. They are running everywhere. They're intermingling with the joint capsules and they are contiguous all the way around all of the different joint surfaces. So at the bottom of your foot, an extremely strong area to be aware of as far as ligamentous stability. And one other ligament we should mention, number 8, that's spring ligament or the plantar calcaneonavicular ligament that is there on the medial side of your arch to give you that little return of energy as it gets stretched out during pronation. And then as you toe off in your gait cycle, it gives you that energy to give you a little bounce in your step. But that would take you through the ligaments. So now we've done muscles, right? Now we've done bones. Now we've done ligaments. Now we're going to fade on to the muscle layers. And you should be aware of extrinsic and intrinsic foot muscles, right? Our main players for that anterior compartment, like tibialis anterior, extensor hallucis longus, and extensor digitorum longus. Our lateral compartment, like fibularis longus and brevis. Our superficial posterior compartment, which includes gastrocnemius, soleus, and plantaris. Popliteus is kind of in a transition area, debatable exactly if it's superficial or deep compartment, but you can look at it there. And then, of course, our deep compartment, which has the flexor digitorum longus, flexor hallucis longus, and tibialis posterior, Tom, Dick, and Harry. And if we look at a side section through the foot, we can also see these muscles and the plantar fascial layers in an excellent side dissection as well. Fantastic. And then beyond that, we can see the muscle layers of the foot from superficial all the way to deep. Please remember there are more muscles in your feet than there are in your hands. And for a lot of us, we are not using our feet the way they're designed. I would encourage barefoot walking and running whenever possible if you've trained up for it. And then, of course, we talk a little bit more about the kinesiology now, where we look at the joint types that we have, also the ranges of motion for each of these joint types, What are the normal end feels? Ligamentous is standard for the foot. The ligaments are just so strong all the way through. I would say ligamentous most of the way as you're looking at it. And then, of course, resting position, closed pack position is a quick summary table there if you are really into the feet. So quick summary of the muscles and a little bit of kinesiology there for you. Then we go into anomalies, and there are a number of anomalies of the foot that you have to be aware of. A hammer toe versus a claw toe, where you can see bunion formation or callus formation, I should say. And whether you're looking at flexion or extension of the metatarsal phalangeal joint or interphalangeal joints, or proximal or distal, the dips or the pips, depending which toe you're talking about. We also have Morton's toe versus Morton's neuroma. So Morton's toe is an anatomical variation where the first ray or big toe is actually shorter than the second ray. This is in about 20% of the population is where we see this. And fun fact, Statue of Liberty is another place where we see this as well. What else do we see? We see Morton's neuroma, which is going to be, do I have a picture of it? Yeah, Morton's neuroma, we'll come to it as a separate condition, but it is a interdigital neuroma in between the metatarsals usually. Second and third and fourth typically, but can occur between any of the metatarsals. Taylor's bunion or a bunionette is going to be one right on the outside where you have your little pinky toe and you get a little formation of a callus and potentially osseous changes in more severe cases, as opposed to hallux valgus. The name says it, hallux meaning big toe and valgus means the distal bone points lateral. And yes, this is the big toe pointing lateral. A lot of students, docs, and therapists get confused around this one. It points towards the other toes. That is a lateral formation. This can result in just a bunion formation in more mild cases or callus formation out here. But in more severe cases, we do get osseous changes as the condition develops. And then, of course, we get hallux rigidus, where somebody will not be able to extend their big toe at the metatarsal phalangeal joint. This is a frustrating one for a lot of patients, and we do have some options that we can do here, but basically involves repetitive load and stretching to that area and ruling out osseous or degenerative changes that could have occurred in that region. All right, as we progress through, we can also see pes planus or the old-fashioned flat foot, and you can have a functional or structural where it is a ligamentous pes planus, where the foot lays flat, or it is structural where the foot is actually osseously different shaped in the bones and laying flat as well. And any combination in between those two can exist, as opposed to pes cavus. You're making this big cave, an ultra high arch on the bottom of the foot. Tarsal coalition is something just to be aware of on your radar. A number of people, I don't know have the exact stats on this, will have areas where the tarsals have actually fused together. So they're not always separate structures. So instead of having 7 tarsals, you might have 6 tarsals when they grow together. Athlete's foot is a fungal infection of the foot. And usually you're dealing with that with topical powders and different things like this. This club foot is an interesting anatomical variation at birth where you get subtalar inversion, talonavicular adduction, and the ankle is in plantar flexion. And usually in North America or developed countries, this is taken care of right away with surgical interventions after birth. And then the last one, we'll do it as a separate condition as well, a calcaneal apophysitis or Seaver's disease. And what happens here is you basically have a growth plate issue, just like a skiffy, same age group, except that this is at the growth plate for the keel or the calcaneus. And it occurs because of repetitive trauma and overuse typically is what you're seeing, and can often be associated with obesity or other issues like that, or a lack of actual training to get up to that kind of load-bearing capacity. So that's a quick summary of foot and toe anomalies. If we progress on, we get into our ankle exam. And again, you can go ahead and refer to our orthopedic assessment text for more detailed exams, or at the start of each body region for the special tests, we have an example of an exam flow that will take you all of 10 minutes. If you are teaching a class or in a class, because you are still in the learning aspect of this, it's going to be better for you to go through detailed, what are my specific history questions outside of your regular history, of course, following your inspection, fracture screen if it's required, and then a detailed palpation list. This is important for our basic anatomical understanding. And again, I'd refer you to the muscle manual right over here, or we have videos of palpation of all of these structures as well. And then you get into your functional assessment. I would suggest to you a squat and rise is a great functional assessment for the lower extremity. Then you're going to go into active range of motion, Then you can go into passive range of motion and joint play if it's required. Then you can go into myotome checks, neurovascular screens if needed, and then orthopedic tests listed by condition. And again, if you need to review how to perform these orthopedic tests and their interpretation, go to the section of special tests on our website in Pro Central. And then, of course, evaluation of surrounding areas, lumbar, SI, hip, knee screens would be there. Absolutely. And then diagnostic imaging if warranted, usually not required. Of course, we have our full physical exam form that is basically a rehash of the exam flow. I cannot remember how to do all this stuff, so it literally means it's a cheat sheet for me to follow. And then I can draw where the person has pain, discomfort, bumps, bruising, scars, whatever else it is on these little pictures. And then you can go through your range of motion, vascular screen, neurologic and orthopedic tests, and places to write down some of your findings. Again, all of these forms are available on our website. As we progress through, we should be aware of a rapid review. If I was a student studying or a doctor or therapist trying to get this information down for board exams or prior to a patient consult, what I would do is go to these pages that give you the quick summary of each condition. And it is there in less than 3 lines typically. So for Achilles tendonitis, painful tendon, worse with running, jumping upstairs, signs and symptoms, tender to palpation, Achilles squeeze, Thomas test maybe, and then a rapid DDX. And we do this for all of them, including the stress fractures as well. Maybe we should talk about stress fractures a little bit rapidly here because it is an important condition for the foot, especially. So insidious onset of pain, better with rest. It is a micro trauma, repetitive overuse injury typically. Tender to palpation, and the most common locations, although it can happen anywhere in the foot, the most common locations are tibial stress fractures, metatarsal stress fractures, and calcaneal stress fractures. And just look for that history of a rapid increase in load or activity without giving the body time to adapt to it. And of course, these other conditions we'll go ahead and talk about individually. Carpal tunnel, what am I trying to say? Not carpal tunnel, tarsal tunnel syndrome. And we can look at compartment syndromes, ankle sprains, Morton's neuroma, all of that good stuff. You should also be aware of pain referral patterns for the leg and foot. Pretty standard. You can see things like a gastrosoleus strain, Achilles tendon rupture. I've seen a few of these in the clinic lately. You can also see Achilles tendinopathy a little bit more distally, usually retrocalcaneal bursitis, but don't call it just that. Retrocalcaneal bursitis secondary to what type of pathology or overload of the tissue. You can also see issues around the ankle, like an inversion sprain, or I should have drawn here an eversion sprain around the medial side as well, tarsal tunnel syndrome, Seavers right around that calcaneus itself, plantar fasciitis on the bottom, Taylor's bunion on the lateral side, irregular bunion or hallux valgus on the medial side. Sesamoiditis is a condition that you should be aware of, where you can have pain over the sesamoid bones. And of course, gout around that big toe is going to be a big one. Metatarsalgia, the good old Morton's neuroma between the second, third, and fourth, usually. And then, of course, heel spurs, but I would call that a osteoarthritis degenerative change or enthesis degenerative change over top of the bottom of the foot. If we progress further, then we're going to get ourselves into our basic palpation again. And I will remind you, there are videos of how to palpate all of these on our website. So please be sure to check those out if you forget. Ankle range of motion is where you're going to start, but the key thing for ankle range of motion is going to be, do I know which muscles are activated, what tissue is stretched, and what tissue is compressed, so I can find what my potential pain generators are? Fantastic. All right. And then moving on, you're probably going to go into some goniometry if you wanted to get more accurate ranges of motion. Then you would do inversion and eversion, dorsiflexion, plantar flexion as a passive range of motion, again, with a list of tissues stretched or compressed. And then we would move on to our muscle testing. And should you have forgotten your muscle testing, here are some quick ones to review. But again, the muscle manual and all of our videos online also have the muscle testing content. So just go under muscle testing under the Pro Central area. Next thing we're going to do is special tests. And I just give some of the key special tests in the orthopedic conditions manual. The orthopedic assessment book, the yellow text, is going to be your choice for more detailed information on that. And I would also, again, refer you to our video library that you can look at that shows all of these tests as well. But ankle drawer tests are good for stability, calf squeeze, Thomas test. Yeah, it's okay. If you can't pick up an Achilles tendon rupture without doing this test, you might have missed something. So you might want to go back and review that condition. We also have a calcaneal squeeze test looking for stress fractures around the calcaneus or potentially plantar fasciitis. Morton's for squeeze test for a Morton's neuroma, or stress fractures of the distal metatarsals like a marching fracture can show up as well. But either way, lots of good resources just to remind you on some of the key special tests that we would do. And then of course, diagnostic imaging. So if you are looking at an X-ray, we can go ahead and show you how the X-ray is set up, how you're going to set up your central ray versus collimation versus KVP and all that good stuff, so you can understand what the view is trying to show you. I would suggest that you understand the Ottawa ankle rules or know how to perform a detailed fracture screen. So a couple of key things. Number one, you can go onto YouTube and type in Vizniak fracture screen. We've got a bunch of great videos up there that you can look at, but you're going to be looking at age over 55, history of significant trauma. Did they hear a snap or pop at the time of injury? Do they have exquisite bony tenderness? Are they unable to move the area? Do they have dark black bruising in that region? Okay. Do they fail a 4-step test? These are your standards for your basic fracture screens. And I would encourage you, just know a generic fracture screen, and then you can apply that to anywhere in the body to rule in or rule out fracture. So here would be an example of an MRI. I got a sneeze coming, so give me a second. Maybe it's not coming. Oops. Let's go back. So here's an MRI showing a stress fracture of the tibia right here. So what you can see is this is the tibia MRI. Yeah, tibial stress fracture. That's what this is. Yeah, top of the tibia. There you go. There's your ACL. Good. Gastrocnemius and soleus, and you can see this region right here of hyper response that we can see that we normally visualize during stress fractures. And we'll talk about this in more detail once we get to the condition. You can also see on ultrasound, gastrocsoleus strains are visible right here, where you can see a tear in the muscle belly of the gastrocnemius. What else? This would be a stress response right here, secondary to a metatarsal stress fracture, where you can see a minor break, a hairline fracture in the bone, and then the stress response around it as the body tries to remodel for that tissue. So that gets you through your basic introduction for the ankle. Lots of good stuff for us to talk about right there. We are going to go ahead and get into the conditions here in just a little bit. But as we progress back, we can go ahead and remind ourselves of our range of motion, muscle testing, pain referral patterns, kinesiology, anatomical variations. We got the muscles, we got the ligaments, we got the bones, and we've got a strategy that we can use going forward because our knowledge base is strong for evaluation of the ankle. Anatomy, assessment, and then pick your actions on a condition by condition basis. All right, thank you very much for your time, and we will see you on the next video.